most important components of the TB and airborne IPC hierarchy, which are administrative controls, environmental controls. Mix of everything is an architectural component of this problem. And if we have any controls available at hands, or we believe that the administrative controls and environmental controls are not effective enough to reduce risk to zero, we need to use something else. And it means, again, the risk assessment. We need to use some personal things to implement to actually stay safe. And I have no conflict of interest to declare. And again, I should mention one more time that there is guidance developed. And most important document for now is the WHO TB IPC guidelines, developed with the close participation of ETTi core group members who stay here. In 2022, a year ago, the WHO reformatted this document and published as guidelines dated 2022, but it's exactly the same content but different format. On August 31, WHO published operational handbook mentioned by Paul, and this is implementation document which provides more detail. And again, the ETTi was involved, and we also continue to developing the operational guidance to NTPs, to people who prefer to stay safe and keep patients and visitors safe in our facilities. I would say that the TB IPC guidelines was very adequate document in pre-pandemic era for airborne IPC. All components are fully applicable for any kind of airborne transmission. And this was actually good guidance to reduce the risk. So the last component of this guideline is recommendation number 7. It's about use of respiratory protection. And I just read particular respirators within the framework of respiratory protection program. Extremely important, not just respirator, but the comprehensive program. Not complicated, but very important to be in place to be effective. They are recommended to reduce MTB transmission to healthcare workers, persons attending healthcare facilities, or other persons in settings with a high risk of transmission of airborne pathogens. The guidelines for TB, but it's applicable for other settings as well. So what's the evidence behind this recommendation? So many studies have been included into the analysis of guideline development group, and I just show you the few. And if you calculate the average relative risk reduction received because of use of respirators in high transmission settings, the reduction was 72%, 72.4%. It's actually a lot. It's not 100%. It's not like 100%. We have no golden bullet to reduce the risk of airborne infection. So we have to implement hierarchy of control, several measures to stay safe. So 72 is a lot. And again, it's based on risk reduction. I should mention one of the administrative controls recommendation, which is number 4, about respiratory hygiene. It's remarkable. This recommendation was based, among others, by the study implemented in South Africa. And we have here the participants of that study, Matsi, Paul, Marty, and others. They analyzed the reduction of airborne transmission of MTB for patients in drug-resistant TB hospital in experimental ward to the experimental animals, Guinea pigs. And several modes have been explored. And one of the parts of the study was transmission risk, amount of animals infected with and without masking for drug-resistant TB patients. So exhaust air from that ward was supplied to the cage with animals, and they calculated the rate of infection among these animals. So why I mentioned the administrative controls? Because respiratory hygiene includes use of masks. It's an important note that it's defined as a practice of covering the mouth and nose during the breathing, coughing, or sneezing, and also wearing a surgical or medical mask, cloth mask, in such settings. So several studies again have been analyzed, and the relative reduction, cumulative risk reduction for the use of respiratory hygiene, and most importantly by using masks, was 47.8%. It's a lot again. It's about half of the risk have been reduced. So what's the respiratory protection program? It can not only just supplying respirators, it includes several components, not difficult to implement, but essential to have a program effective. So about risk assessment, and it's very important to analyze in what environment you actually exist and you enter. And for example, I can see few attendants who use respirators today. It's based on their risk assessment. They believe that it's not safe to stay here because of several factors. Yaku mentioned some ventilation problem in the building, crowding, distance, maybe some health problems. So we have to think about the risk and assess risk. So who are the highest risk transmitters? It's true about both TB, SARS-CoV, and new airborne pathogen, who will cause the next pandemic for sure. Nobody knows when, but probably it will happen again. So most of the transmission occurs from undetected, undiagnosed patients with airborne infections. If you are talking about TB, it's patients who do not receive effective, means DST-based effective treatment regimen, who have treatment delays, interruptions, defaults, ineffective treatment regimens, not based on DST, and patients who are on palliative care. For fluoroquinolone-resistant patients, during the first 2 weeks probably, the patients stay probably infectious, and there are several indicators of infectiousness. It's actually a hot topic for the research, and again, we have to analyze what environment we stay in. What other factors? Coughing people, visitors, patients, other respiratory symptoms, cough etiquette in this facility, mask use, diagnosed TB patients. What are criteria of infectiousness? We do understand that sputum smear microscopy status is not a good indicator if the patient is on the treatment. How adequate the treatment regimen for the patient. Indoor environment, already discussed a lot. I will not stop in this. Existing controls, the effectiveness, the maintenance, the design, and other factors to be considered. Work practices in this facility. Are there aerosol generating procedures? Are they done in isolation and safe mode? Are there good work practices among the staff? And very important factor is subject susceptibility to infection. So based on risk assessment and having a particular facility, we have to put signage and mark the high-risk transmission areas with special signage. It's in Russian from my practice. It means safety first and do not enter without a respirator. And it's important that the respirator should be fit tested. It's very easy, feasible procedure to do. We have a short practical session, and we'll do with you the fit test, fit check, and we'll discuss other practical issues of the respiratory protection program. And so we'll more detail in the practical session. Education of staff population, and so on. Should be initial instruction on and fit testing for all new members of the team. Annual airborne IPC training, which should include the risk assessment again and respiratory protection education and training. annual qualitative fit test for all staff. It should be the standard globally for all healthcare facilities, not just for TB facilities. And again, it's very feasible procedure, easy to do. And posters and signage reminding about the risk and need to use respirators. I should mention also the use of elastomeric respirators, which are more expensive for one piece, but less expensive during the long time of the use. So for highest risk procedures, and if staff prefers to use elastomerics instead of disposable respirators, they should be also available, I believe. It's less costly actually. So in facilities, it could be used for cough and sputum induction procedures, bronchoscopy, intubation, autopsies, most high-risk procedures. How we can find out which is the most high risk? Based on the surveillance of staff, on incidents, analyzing new cases, analyzing the latent infection among staff. So how many respirators we should supply? There is a recommendation based on my experience. But you can develop your own guidelines, how much respirators you supply. And I just use this recommendation to supply 1 respirator per 2 working days for the high-risk area staff, in medium-risk areas for 5, and several in reserve to change during day. And for low-risk areas staff should be at least 1 respirator for 10-20 working days. So you can calculate how many respirators for the facility, region, or country you actually need. It's important to have several models, several sizes of respirators, and we actually in contact with GDF and promote to several models, several manufacturers, several sizes should be available for NTPs to supply. And this should be based again on respirator fit testing results, because of different shapes of face, size of face, configuration, in different continents, different models actually fit better. So the procurement is extremely important also. So the models and sizes should be based on fit testing. And during the pandemic time, production of respirators exploded globally. Unfortunately, lots of respirators not compliant with the standards, which are actually explained in our ETTi website info sheets. You can again check website for the materials. And you have to analyze what actually you have. A couple of pictures of people, of the respirators, which are not actually good by design and cannot provide good seal and cannot filter actually infectious aerosol. So should be taken into consideration. Good resource to check if this particular model of this particular respirator is good for your staff is NIOSH CDC webpage, and you can check easily what was tested, what was approved, what was recommended. Hot topic is reuse of respirators. And there is official definition of NIOSH standard. And single-use respirator means a respirator that's entirely discarded after excessive resistance, sorbent exhaustion, or physical damage renders it unsuitable for further use. It means when you have a respirator used before, but it provides good fit, not contaminated, and does not create extensive resistance, you can reuse it easily, because the transmission from the surface, from the particles which are attracted to the fibers of the filter is extremely highly unlikely. So the contact infection can be spread from the respirator, but not airborne infection. So if we mean TB, it 100% airborne. SARS-CoV-2 is mostly airborne infection, but a little bit risk of contact infection. So for TB, the respirator can be reused without any risk of increased transmission. Healthcare compliance improved significantly during the pandemic time. There was huge demand for respirators, and it's not actually a hot topic now, but we can actually deal with some reasons for compliance and can fix this problem, and it's usually not a problem now. Disposal of the respirators. So I already said that realization of infectious particles from respirator is extremely unlikely. There is a risk of contact infection from the contaminated surface, but airborne infections do not spread from the used respirators. Used respirators which cannot be used again, they should be disposed with other contaminated facility materials according to national standard for medical waste. So again, the program includes several components, and we have to pay attention to every component, and we have to have a coordinator in the facility who will take care of the monitoring and evaluation of this program, and based everything on risk assessment and fit testing, and supply the respirators which will save health and life for our staff members and visitors and so on. One more time, I remind you, please check website of ETTi, and there are several info sheets, materials developed by group members, and 2 of them are dedicated to respirators and respiratory fit testing. We will develop more, and I invite you to join our activities and also add your experience and your knowledge to these resources. Thank you.